All right, to be mindful of everybody's time, I'm going to go ahead and get started here. So thank you and hello everyone for joining us on today's webinar. We are here today to talk about rural GME and highlighting essential tools and resources from the RRPD and THCPD Technical Assistance Center. This event today is being recorded. The link to where the recording will be posted will be sent in an email following the completion of the webinar today. My name is Caleb Lozinski, Outreach and Education Coordinator with the National Rural Health Resource Center, who is providing this webinar today. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through the chat box, which is located in the bottom ribbon in the middle of your screen. If you haven't already, please take a moment to type your name, title, and organization in the chat box so we know who is joining us today. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the TA provider for the Delta Region Community Health Systems Development Program. The Delta program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. Today's speakers, I'm going to go ahead and pull up one pre-polling question. So if you'll just give me a second to pull that up here. It's just one question in relation to the rural GME knowledge. It will do a little bit of post-polling at the end, and it helps us measure knowledge gained on events like these. So, to introduce our two wonderful speakers today, we have Shawnette Alford and Austin Palacios. Sean Alford is the Assistant Director of Rural GME for the Kiran Patel Institute of Graduate Medical Education and the Executive Director of GME for the proposed Orlando College of I'm going to butcher this name, Shawnette, so I apologize. College of
Osteopathic.
Osteopathic Medicine. That's a word that I do not see often, so I appreciate that. With over 15 years in GME, including as project director and assistant director of GME for a program that received an RRPD grant, she also serves as an advisor with the RRPD THCPD Technical Assistance Center. Austin serves as program coordinator with the Rural Residency Planning and Development and Technical Health Planning and Development, where he oversees data management and dissemination. He is responsible for executing updates to the THCPD and RRPD websites and managing data inputs for program profiles and assessment data. Before transitioning this role, Austin dedicated 12 years of military service as a medic. He takes great pride in supporting programs that address the medical needs of underserved communities. Thank you so much for Shawnette and Austin for being here today and speaking on this topic. I'm going to go ahead, stop sharing my screen, and let you take it over. Thank you so much.
Thank you so much, Caleb. Can you go ahead and see my screen?
Yep, it looks great.
Thank you so much for that introduction. Hi, everybody. My name is Austin Palacios. Today, we'll be going over getting started with rural and underserved GME tools and resources. So I do have to go over some disclosures first. So RRPD TAC is supported by the Health and Resources and Services Administration of the U.S. Department of Health and Human Services under a cooperative agreement. THCPD TAC is supported by HRSA as well under the U.S. Department of Health and Human Services under a cooperative agreement. The content are those of the presenter and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. Okay, so some of the objectives we'll be going over today are understanding the benefits and impact of creating a new GME program in rural and underserved areas. Next one is learn from a case example of rural residency program developed from cohort 1 of RRPD. And lastly, identifying the resources to support development of rural and underserved GME. So the first question and why we're all here is why train residents in rural settings? Well, in rural settings, we have experts in these areas with years of experience to share. And it's true, where you train matters, and the location and the community that is built through this process. And in that same sense of community, it aligns with the phenomena that residents are practicing within 100 miles of where they train. We see that residents who go through these programs are more likely to practice in these rural and underserved areas. Also, lastly, an effort to increase a current 2% of residencies which occur in rural areas, we're hoping to increase and really impact that number starting these rural residency programs. And so what support is available to launch these programs? Well, HRSA's RRPD program supports up to $750K per grantee to develop new rural residency programs. And as of today, RRPD program has awarded $64 million to 84 organizations in 6 medical disciplines. And so there's 2 pathways in the most recent funding cycle that we observe. So we have our general primary care and high need specialty care, such as internal medicine. And we're also seeing an increase in this cohort 6 of family medicines with an emphasis on obstetrics and also mental health. Funding support startup costs to establish new rural residencies include accreditation cost, faculty recruitment, faculty development, and resident recruitment. And states are increasingly funding planning and development for rural GME. Some of those examples would be Wisconsin, Indiana, California, and near and dear to her heart, New Mexico for Shawnette. So for your awareness, this is the most updated notice of funding for 2024. We are expected to see the next one come out this November, so be on the lookout for that. As we go through, you'll understand this a little bit more, but we'll have this posted on our website under the Getting Started tab and frequently asked questions. We'll go ahead and get the most updated notice of funding as it comes out to us. So now I'm going to go ahead and hand this off to Shawnette, who is currently an acting advisor for our cohort 6 grantee. She was an early grantee herself with cohort 1, which had a successful launch of that program. And she has firsthand knowledge of starting a residency program and all the intricacies. So Shawnette, I'll go ahead and hand it off to you. Thank you so much.
Thank you, Austin. Everybody, I just wanted to say I had a great journey to residency, and I will tell you, going from an urban program to a rural program was very difficult because things are not exactly the same, but we were luckily in Alamogordo, New Mexico. We were cohort 1 grantee, and our mission was to train family physicians to provide evidence-based, compassionate care to the people of Otero County and surrounding communities. And some of those surrounding communities included like the Mescalero tribes, a Air Force military base, and a lot of small communities, Tularosa, and 2 mountain communities, and Rio Dosa, which is a tourist attraction. So, next slide. So I'm just going to take you through our journey so you can kind of see how we develop, because it's not always, you know, roses in the beginning and everything's going to work out. But our hospital was a GME naive hospital system in rural Alamogordo, New Mexico. It's a rural designated community hospital. It had inpatient psychiatry unit that had ECT, which was great for educational learning. We had several OBs. We had general surgery, inpatient rehab, ICU, ED, other outpatient practices. So a lot of our IM specialties were actually in our town, which was very lucky for us. One of the things you have to do in the very beginning is kind of identify how are we going to start this residency program. So some of this stuff happened before I got there. So they had selected the family medicine program director. She was board certified. She was one of the youngest members of staff. She had already been teaching some of the medical students that were in a urban area near us, and she was native to New Mexico. So who better to lead your program than somebody who understands New Mexico, right? Before I was hired, they hired a consultant to help assist with their application. It was submitted by the program director herself. At that time, they did not have a program administrator, so program coordinator was not there yet. Their DIO was offsite because they were their sponsor institution, which I'll go into a little bit later, was a urban site in Las Cruces, New Mexico. And they did not have people on site to help with the application. And their Skype visit was scheduled for April 2018. I interviewed April 2018. And funny thing, I interviewed the day of their site visit. So some of the things they did was kind of look at the cost report. So if you're thinking about getting into residency, one of the things we're gonna do is look at the cost report and make sure you've never had residents rotate to your site. If you did, you'll identify some issues maybe. So one of our issues was we had residents come to the hospital before. So we were lucky because if your residents come to the hospital and you don't claim on your cost report, your per resident amount, the amount you'll get reimbursed for residents training at your site would have been set at 0. So we were lucky that the surgery residency program that came to our organization had been established before 1996. And as you go through this process, you'll learn about why that year was important and what that change to the Medicare reimbursements did, but we won't go into that detail today. So RPA was almost at a 0. Luckily, it was not. And then New Mexico had a state plan amendment that was being worked on, which got you up to $150,000 per resident every year. So that gave us a source of funding for startup. Next slide. So some of the challenges that we went through is when they first submitted the application, the accreditation was withheld. They gave us a number of citations that we needed to address in the community and the application itself before they could go back through. While we were waiting for the ACGME accreditation, I looked at the clinic space. When I went to the building, there were no administrative offices. So something you have to consider is when you have a residency program, you have to have a place for your program coordinators, your program directors to do administration work. There were small conference rooms. It was the size of a large office. Not enough exam rooms. You need to have, and for family medicine, I needed to have 2 exam rooms per resident while they were in clinic. And then we still had other providers that were in the clinic. So they shared the space for urgent care and family medicine. So they thought the building was big enough. It wasn't. And they spent $2 million renovating the space. It wasn't on the main hospital campus. And that's not a big deal in most cases, but it does make it easier if your clinic is on the campus of their specialty rotations where they can go back and forth. And if they have a delivery, they can run and do a delivery and come back. And then there was no room for medical students. So becoming a teaching health center, you want to kind of consider all learners. And that was one of the things that were important to the family med program that I was working with. And then I found out there was not a lot of engagement in our faculty. So a lot of our faculty who were from surgery or ortho didn't really know what was going on and didn't understand what the program was and that they had even submitted an application. And then all the marketing and all the talks that they were going to do were actually prohibited because this all rolled out right around the time of the pandemic. So you can imagine how you can't do everything you plan to do with lunch and learns and talking to your community if you can't actually go face to face. Next slide. So one of the things we did was start initiating some changes and actually do some planning with the application. And that's where this toolbox would have come in handy for us had we had it at the time. During our challenge, we increased faculty engagement. We started having more of the specialty faculty participate in program evaluation committees where they design the program and in clinical competency committees where they evaluate the residents in the program. We had quarterly faculty development meetings because if you feed them, they'll come. And at those meetings, we started seeing people talking and talking about quality issues and evaluation things. And so we can make program improvements every quarter based upon and collaborating with the faculty. We had a program manager, which was me at the time, rounded with each faculty member monthly. So I would go over, I would take cakes, I would take pies, whatever it was that they loved. That if they were an Eagles fan, I would drop off something with that. And we just engaged them and showed them how to get into Innovations, which is the data management system I'll go into later. And we really kind of put the work in to make sure everybody felt they were a part of the program that was being built for the community. So our program director and myself, the program manager, worked with the hospital system to get data and resources needed to resubmit the application. So in your ACGME applications, there will be a whole bunch of categories you'll have to provide data for. And so we had to get with the quality team. We had to get with the electronic health record teams. We had 2. We had Athena for outpatient and we had Cerner for inpatient. And we had different teams who pulled that data. So you kind of had to identify your champions who understood how to get this data and the data that would be needed to report on an ADS every year. So we really focused a lot on getting the credentialing team established because if you can't have them credentialed to work at your hospital, it won't happen. So they needed to figure out how to get DEA license and get them licensed and different things in the state. So they had not been talked to in this whole process. We brought them in. We tried to think about the entire process as we built this. And the C-suite, which is your more valuable, that's hopefully who we're talking to today. We met with them pretty much monthly. here's the updates, here are our challenges, here are our wins, here are the things we still need. And then we did a lot of education. They could come ask me, well, okay, Shawnette, what is this? What does this mean? So we did a lot of the education. So plan to do a lot of education with everybody in the health system, not just your C-suite, and that'll be easier to roll out these things. And then we did a lot of lunch and learns. We wanted to, like, once we were able to meet again in person, we decided to go to the Rotary. And the Rotary asked a lot of questions about the community. A lot of those are really important people in the community. They will brag about good things the hospital system does. So we did engage there. We went on radio. We talked to the newspaper article or reporters, and we did try to think about how do people in the community get information, and we tried to address all those different areas. And then we talked to the employees. That was really important. You know, we want them to engage with our residency program too. We want them to come to our clinics, we want them to use them as their providers. So we did a lot of different marketing and prep for this. Next slide. That's when we found out about this lovely grant that we applied for. We applied for the HRSA grant. We had a grant team assist us with the application process, but I found out quickly that there's a lot of work that you still have to do to get it up. So we did that. We applied for it. We did needs assessments. We got performers. We got different members of the community to help with all the stuff we needed to submit, and we submitted. And I was shocked when we were awarded because I had never worked on a grant before, and this one was accepted. So I was super excited. In that process, you have to work closely with your finance department. That's invaluable. And making sure multiple people in your finance department are involved, because turnover sometimes happens throughout the course of 3 years or 2 to 3 years of your grant. And I wanted everybody to know that the residency budget was there, the CME cost reports, how all the data that's needed to be requested. And then after we did this, at the same time, we were resubmitting our ACGME application. We were resolving all the citations. We addressed program requirements that were missing. And we reviewed it with the DIO at the GME Graduate Medical Education Committee meeting. And then we submitted it. Next slide. Great news, right? So we had some setbacks, but we had some achievements that come in. We received that grant. Judith Powell was our technical assistant advisor. She was invaluable. She helped me through everything, all the questions I had about specifically rural health and how to get things accomplished when there's not a team to do every single thing. You're going to have me versus having 5 people. So I was also the project director. So I was responsible for managing the grant, providing quarterly reports, and kind of just talking to Judy about what challenges I was facing. And she would tell me what I could do, gave me great advice. She spoke to our C-suite for us. And then we just had to work on monitoring the finance reports, which were done in 2 different systems at that time. We received our ACGME accreditation, which resolved most of our citations, which was great. And then a year later, we received continued accreditation with no outcomes, which is your best case scenario. That's what you want to aim for. So I know that doesn't sound like a big deal now, but it really is a big deal to get to there with no citations. And then we were able to recruit in the main match. So we got our accreditation in October. We were able to register for ERIS, which is the electronic residency application systems, which is how people apply to your program. And an NRMP and the National Residency Matching Program, we were able to recruit our first class all in the main match. So that is your goal. When you start a new program, you want to be in the main match. If for some reason you don't match, you have to do SOAP, which is the supplemental offer and acceptance program. And that basically is a mini match. It's 4 days of redoing the same process, but quicker. So we really don't want to do that. We want to kind of match all your programs. So that's a great achievement. And that's what your goal is good to shoot for. And then we solidify our partners, like our community partners. We were a community hospital in a rural area. We partnered with an urban hospital, and we worked hard. I went there every Friday and visited our residents to make sure they had a presence of us at that hospital, and they didn't feel like they were alone. We did joint press release with each hospital. We had 2 teams working together. We would share hospital equipment because during the pandemic, one hospital might be short something, another hospital isn't. So we worked together, and our residents got to see all that. So we shared didactics and everything in a time that there was less providers. Next slide. So the things I didn't know, and these are kind of my pre-lesson learns, how big community involvement is in rural health. I could not have done what I did without involving several members of the community. They were pivotal with the success, and they brag about your program. If you get them involved early, the non-hospital employees, they will help you achieve your goals. I was blessed enough to have a local community member who decided she understood the process of residency. She understood that residents, when they come out of medical school, have a lot of debt. So she gave $2,000 for every resident every PGY year that they came, just as a gift, just because she didn't have children and she wanted to give back to the community. So that was one of the things I found, like involving community with needs, they will give. I didn't know how valuable that toolbox would be that Austin will show you guys in a little bit. There were so many templates and documents, because if you've never done this before, it is difficult to try to figure out your road. How do I get there? How do people get this done? No, we can't do it in our community. Yes, you can do it in your community. It might take you a different time than another community, but it can be done. And then you understand that finance is important up front, making sure that you understand how you're going to get your CME funding. Are you going to use THC funding? Like, what ways are you going to sustain your program? How your clinic revenue is going to happen? Are you addressing your billing and coding? Do their team know about the GC modifier? So these are all different things you have to tackle. Understanding that you have to figure out how much you're going to be reimbursed per resident, and then making sure you understand how the model works with that. And then your rollout in a hospital is important. If your hospital employee or your health center employees don't know about the residency program, and they go to another clinic and they're like, I don't know what that is, that's not good. You want to make sure everybody in your company can kind of speak to some sort of like, oh, a residency program is to provide a sustainability plan for our community. That was really important, and just kind of get into every department. So as a residents don't just stay in one place. They go all over your health system. They don't just stay at the family medicine clinic. They don't just stay at the psychiatry clinic. They go to different areas of the organization. So make sure everybody knows. And then data management is really big. You're going to do a lot of reporting. So getting like a new innovations, a med hub, some kind of data management system, so that you can report to ACGME every year that they request information, and having a good EHR is very, very important. We were blessed to have a good EHR system that had good data reporting, because as you know, each EHR system has different levels. And if you have a really good one, it's easier to do all this. Next slide. So the program impact. So right now, it increased the staff morale. I mean, we were one of the only clinics in the health system that didn't have a high turnover rate during the pandemic. We had 0 turnover throughout 2 years. The staff kind of bought into it. They did a practice management rotation where they sat at the front desk, they sat at the MA station, they went through the whole entire clinic to understand what can prevent a patient from getting back to you on time, and kind of see how to prevent insurance things and authorizations, things like that. So the morale in the clinic was high. We did a lot of Christmas parties together. We did a lot of outings together. So the morale was high. Everybody was happy. And then like we had access to more resources after the grant. We could go to this toolbox. We can get access to things. What is everybody else doing? Let me look at this webinar. Let me see what this program did. Like, we could learn from each other. And this was our physician sustainability plan. Our average age of physicians was 68 at the time in our system. We literally had faculty who were like 79 working because they felt like they couldn't retire. So we wanted to change that. We wanted them to have a community where they felt like they served and they could now enjoy it. And then it just increased access to care in the community. We had more doctors coming in, and each doctor has their own, things. And one of them is wellness. He did a lot of holistic approaches. He did OMM, things like that. And then we have faculty service development. We have our former faculty member who became an attendant, and he's now helping develop an FMS service. That's awesome to have an FMS service in a rural hospital. So that was really big. And it takes about 3 years, everyone. Just so you know, this is not something that's going to happen overnight. The average time is 3 years to develop a program. So you can look at me, and because I did it a little faster because we had done a lot of work before the day I was hired. This health system had already done this. So as you think about this, there are timelines available on the toolbox on the website. You can go in there and say, okay, this is the timeline to everything. This is what I should be expecting to see. Next slide. And one of the things that you'll see is that I went from being a grantee to an advisor. I can't imagine when Lori, who's on this call, first asked me to be an advisor, I was like, I don't know enough about this, but you realize you do know enough. Once you go through this process, you're going to become an expert in things that you never thought you were before. You're going to really be able to tell people your lesson learned. So as I advise some of the programs, I'm like, here's what I learned, and don't be like me. Don't do this mistake. Be very proactive about rolling out these things and ask a lot of questions. it allows me to stay active in rural. I am in an underserved community helping a federally qualified health center, FDHC, roll out residency programs. They're already 2 in. They got accredited for 2. They never probably thought they were going to do that now, and they're applying for their 3rd one, which is going to be coming up next year. And they both applied for grants and got those. But there's also resources, right? I get access to resources as I'm still growing as a GME professional. I share them with you guys. Austin is great. If there's anything that's missing from the website, he'll make sure it gets added. So there's a great support team that works with this grant. But also, if you don't have a grant, you can just go on the website and utilize these things and develop these programs. Next slide. Thank you, Austin.
Yeah, thank you so much, Shawnette. That was really a lot of great information. So I'll be going over exactly what Shawnette was talking about, those useful tools she had mentioned that the Technical Assistance Center provides, and resources. So here we have the landing page for RRPD. The next slide will cover THCPD as well. And so we want to show you this slides to get access to those tools and resources. They are available to general users. And to become a general user, here in the I want to get started portion right here, you can go ahead and click that. That'll prompt you to enter an email and create a password. And then you'll have access to those that toolbox that Shawnette was referencing earlier, which I'll be going over. And once you do make an account, you will be notified of upcoming webinars or any changes to GME through that email. So this is what the THC website looks like. So on this same page that's publicly available, you don't need to have an account to see this page. This is where you'll see where and when we are presenting next, as well as stay up to date on all things GME with our webinars. So each month, THCPD and RRPD host a webinar that cover a wide range of GME development topics and specialties. And the good news is, if you're unable to make it to any of these webinars, we do house all the webinars and the PowerPoints on in our toolbox, so you can reference the webinars there. These webinars are open to anybody who's interested in GME to attend, so the more the merrier. We also have our social media accounts. We have our X page for both THCPD and RRPD, which cover grantee spotlights, presentations, new GME changes, publications, and changes to our websites, as well as amplifying some of the great outcomes that our grantees are doing. We love to amplify anybody who's doing great work in the GME space. We have a dedicated team to make sure our social media accounts are all up to date frequently. We also have a LinkedIn, so feel free to follow us there. It's at Rural GME on LinkedIn as well. This is also on our landing page, and this is for getting started, which just pretty much covers some commonly asked questions that we've seen over time. So clicking that expand plus sign right there will give you a little bit more summarized version to answer those commonly asked questions. Once again, you do not need an account to access this. And to create an account, there's another prompt here. So you can create an account here and enter that email and password as well. So this is our rural residency program and rural rotation site map. All right, this is just showing where all the rural residencies are in the U.S. You can use this map to identify residencies in your area that are starting and in programs that are training in the U.S. And you can learn about them, and the website link is provided in case you want to connect with them. And next, if you're interested in seeing programs that have started RRPD programs on our website, this is also publicly available. And these are just the program profiles that cover percentage training in medically underserved, the class size, as well as training locations. And even Shawnette's program is highlighted here too. So you can see all the great work they're doing by clicking on that program profile and then using that website link to dive in a little bit further into what the program offers. So once you do make a user account. You'll be prompted to this page once you sign in. So for general users, you will only see the toolbox, the hospital analyzer, and getting started. Those are the only icons that you'll see in this section. This is actually the view from somebody who is assigned to a program. They'll have this program box right here. So the first one that we're going to be covering is once you click on getting started, the Real GME portal roadmap will pop up. And actually, Shawnette, we'll go ahead and cover the roadmap for y'all.
Yeah. So this is a cool place. Like this is what one of the things I was referring to when I said I wish I had kind of these things before I started. So you'll see there's different stages. There's 1, 2, 3, 4, and 5. Stage 1 is exploration. Like you're just starting to figure out like, okay, can I make this happen? Is this something that my community can do? So when you look at that, you'll see it starts with community assets. So you might say, identify community assets and interested parties. So, you know, that could be your board at your health system. It could be your Rotary Club. It could be your CEO. It could be a number of people, but you have to figure out who would be invested and who's your community assets, right? And then you're going to kind of assemble a leadership team. Okay, who's going to drive this? So you got to identify somebody who's going to drive it. And you just really want to figure out what is the mission of this? What are we trying to accomplish on this? So that's when that exploration stage is. So you'll kind of go through your leadership, your sponsorship, figure out who do you want to sponsor? So you need to have a sponsoring institution to do an application. And that's what ACGME requirements. So a lot of people partner with bigger organizations to be part of their sponsoring, or you can start your own. And then there's an application process for that. So I have grantees who have started their own SI, and their plan in the beginning may not have been to start their own SI. It was to use a bigger institution, but they realized, you know, it's better if we just have it and do it either themselves or in a consortium model. And then you go to stage 2, you're going to design your program, right? So that's when you're going to like identify at least an interim or an initial program director to be on there. So in my case, our person that we identify as the program director stayed on throughout the whole process. And so she is still there as the program director. But a lot of times you might have somebody who says, you know what, I'm really close to retiring. I'll help you guys get this up and started. I'll help you guys recruit for your program director. Sometimes you have to even train them. You may have to start the program. That person's there a couple of years, but we find somebody. You're going to talk about financial planning. You're going to think about starting an initial budget. How do I sustain this program? How will we be able to make it happen? And so that's where financial planning goes in. You do a pro forma. You identify all the expenses, all the costs, how you would get reimbursed for all the costs of training, and you go through that. And then, you know, you're going to apply for your sponsor institution application. Now, if you're someone who's already under somebody else's SI, you might start to think about, okay, I'm going to start applying for my own program application for family med or for IM or for psychiatry. That's where the stage is. We're designing it. We're kind of figuring out curriculum. We're trying to figure out how will we make this all work. And then stage 3 is development, right? So you're going to appoint a program coordinator. So your program coordinator or manager is the person who's your right-hand man to the program director. So the program director is responsible for the whole entire program, the oversight, but you have to have somebody who can do administrative work with you at the same time. That person will help you with contracts. The person will help you with curriculum and getting it on websites and getting your program, your data management system in place and trying to figure out how to do the maps and help you with the actual application. And then, you know, just applying for accreditation, that's a long process too, but none of these stages have a per se time. There are sample timelines, but again, these have to be thoughtful for your actual community you're in and what you have available to accomplish in. And then stage 4 is great. You've done all this stuff. You've done the applications. You got it accredited. You got to market. Like, how I'm going to get people to come to my residency program in the middle of New Mexico. And that is always a challenge, right? Figure out how to get somebody into these communities that you love so much, but you have to figure out a way to get them there. So marketing is big, and the infrastructure of your program. What can you offer? Do you have a affiliate where you have simulation labs? You got to be kind of mindful about thinking about that. And then creating websites, and then creating your annual budget for your program, and just completing your first match, going through your residency application system and finding residents to come there and getting them credentialed to start. And then after you've done all 4 stages, you get into that great promised land of maintenance, right? And throughout that maintenance is where that sweet spot is. Like, okay, we did it. We did the hard work. We kind of identified we're in a good place. So that's when you're going to like, okay, what's my plan for recruiting residents? How am I tracking any of the data? Where are they going after they graduate? How do I retain my faculty? You know, you can train them, but you want to train to retain, keep them in your community. So that's where that stage 5 maintenance goes. So this map is there to kind of guide you through your process. If you're a grantee, you'll get this map and you'll go through each and every objective with your technical assistant advisor. But if you're not and you want to use this, I would still use this. This is a great tool to do to develop your programs.
Thank you so much, Shawnette.
Mhm.
So the next icon that that'll be available to you if you make a general user account is the hospital analyzer. And so to use the hospital analyzer, you'll first choose your state of interest. Once you've selected your state, another list, a city list will populate, and you can go ahead and pick your hospital that you're interested in getting more information on. Once you've selected that hospital, a PDF report will download for your review. And so this is an example of a hospital site in Alaska. And so hospital funding is very complex. And so we really recommend that whenever you are developing your site selection for your program, that you do use the hospital analyzer so you're not caught off guard and you're really aware of all the opportunity comes with the various categories that hospital site lands under. And so definitely encourage you to use the hospital analyzer. The next one that you'll get, the next icon that'll be available to you is our tools and resources icon. And so this is a one search tool. You just click an icon that you're interested in. I do want to note that here you'll see the icons, and there's on that roadmap we just went over, the icons were exactly the same. And what we wanted to do is really facilitate as you're moving through the stages, you know where to go if you need further guidance, or let's see what other people are using once they're in that stage, and really looking at whether it be community engagement, program development, financial planning, institutional sponsorship, accreditation, and program implementation. And so this is available to you as a general user as well. So this is the most commonly used way to search for tools. We do have hundreds of tools at your disposal. And so we tried to make this as user-friendly and allow you to narrow your search through these various filtering categories. So we have section, type, and specialties. I also want to note that we do put a lot of emphasis on using data to drive our toolbox, and really looking at the click data and seeing what tools are people looking at, what tools are they most using, and we even add a little option here to give it a thumbs up or a thumbs down. And typically we don't have thumbs down, but we have thumbs ups, and so that's really good information because we're putting out these tools and we want them to be used. So here we have two examples of tools available under the financial planning category. So we all know that GME financing is a big topic, and so we want to make sure that we have these tools provided for future grantees or existing grantees. And the first one are prime hospitals for GME training. Okay, this is a high-level overview of rurally located hospitals that are not currently training medical residents, but may be candidates for such. So taking a look at that and seeing if any of those are close to you or that you know about them could be beneficial to program development. And the next one is hospital type and data lookup file. So this goes over by state and then by hospital, the CMS rules changes, DME and IME FTE caps, and money claimed. So I encourage you to look at all the resources that we have. I know I've heard it from Shawnette before, and she wishes a lot of these tools were available in the early cohort 1 stage. And so it's really nice. Cohort 6 and all our future cohorts, they'll even have a more robust toolbox to use. Next is our research. So like I said before early on, if you did miss our webinar, all our webinars are located in our research. You'll also find that we have published material, manuscripts, any kind of media presence, newsletters, and reports. They're all captured here under our research. and we allow you to filter for a more focused search. Additionally, we host our annual grantee meeting, which we just had in August, 399 in attendance. This meeting is open to non-grantees as well. And I do want to note that this year we had a lot of feedback from attendees that really expressed the opportunity, how great of an opportunity it was to network and meet like-minded people in the GME space. One of the most notable things from this annual grantee meeting that really grabbed my attention and I got the pleasure of sitting in was the introduction sessions, one of the earlier sessions in the meeting. And at this, it was broken down to East, West, and then Central. And at these meetings, each person stood up and represented the program or a future program that they wanted to start. And at these region introductions, you really start to see the networking, the wheels turning, and what partnerships that might be able to occur, and similar barriers for their region that they were encountering, and different kinds of remedies for those barriers. And so that was really cool to see happen at the annual grantee meeting.
Yeah, and just to piggyback on what Austin said, it's a lot more willingness for transparency, because people are really willing to say, hey, here are my barriers. Here are the things that I am experiencing, and you learn. And you're like, oh, I'm having similar barriers. Hey, can I come up to you afterwards? What are you doing to address this? You know, and I think that natural networking that Austin just mentioned is the biggest like win from these conferences. Like I've been going for a couple of years now, and I remember when we were in a small room, and now it's this wonderful big room of collaborators and just teachers and just the education that goes on throughout each program to other programs. It's really invaluable to be there.
Exactly. Thank you so much, Shawnette. And so this effort is not something done alone, and nor should it be handled that way. It takes a wide range of partners to make this happen. You can see the plethora of partners that the Technical Assistance Center takes pride in really bringing these partners together and making connections with the grantees to ensure that we help grow GME in the most effective way. And so many of these, I would say many of these, if not all of these, were actually present at the annual grantee meeting. And you know, we had tables. We had a whole partner session where tables were set up to where you can meet and greet each of these partners here on this slide. So now we'll go ahead and open it up to any questions that you might have. And I'll go ahead and turn the slide. So this is also our contact information, but feel free, any questions, just go ahead and drop them in the chat and we'll address them.
As we wait for those questions to come in, I'm going to go ahead and launch the post polling. But feel free, everyone. You can either come off of mute, or if you don't feel like talking, you can always put your questions or comments in the chat box as well.
Is anybody considering starting a residency program and has any challenges that they think they might encounter that you might want to hear our perspective on?
Well, Shawnette, while everybody is like thinking about their questions, what's one thing that you would recommend? You know, if somebody's thinking about going down this path, like what are some things you can do to get your health center, your hospital, your organization ready to launch a residency program? What would you recommend?
Yeah, you know, I think one of the biggest things is it depends on region, right? If you are a rural program to considering doing it, I would say, where are your resources at? Assess your current resources you have within your own teaching health center or your own region. So I was a little different because we were a bigger health system within a rural community. So we had a hospital, which was a community hospital. We had a lot of outpatient specialties already in this city, but that's not the case in most places. Most people have to send the people out for endo and gastro and all these different subspecialty of internal medicine. And so I would say identify all the areas of the program you want to start. So if you're thinking you need family medicine docs in your community, you want to say, okay, I need to find out what are the requirements to have a family medicine program here. What do we currently have? What kind of resources do we still need to get? what kind of financing do I need to get to support this, and reach out to those who did it before. So you can reach out from, if you use the info@ruralgme.org, that is your go-to for questions. I have used that info email, like, hey, everybody, this is my question. Can you share this with the advisors? So for instance, even this year with Lori, she understood, I've been in GME for almost 15, 20 years, and a question came up I wasn't sure of. If you're a federally qualified health center, how do you get DEA licenses for residents? I was like, oh, that's different because they're not a hospital. I'm used to your hospital already having a DEA number, which is just assigned to residents. Well, I found out through sending an email to the group that you have to actually just apply for it as a teaching health center. You can do it. So there are things that are going to come up, and identifying things that you don't have a process for. I implore you, as you develop processes, to develop protocols and document it. Keep them somewhere that if somebody else leaves, somebody else can pick it up. So as you're developing everything in steps, keep a shared folder or shared file of residency development somewhere in your system. Put all the different protocols you had to put in play. Get your policy committee involved earlier, making sure you have committees for your residents. There's different things that happen that you don't think about that you'll learn throughout the process. But I would find the closest community to yours who have already started a residency program and reach out and start it. But that info@ruralgme.org or info@THCGME.org, they will get back to you. If there's somebody, they send it out to all of us in the technical assistance center. A lot of times, most of us have gone through a similar issue. I will tell you, if you do apply for the grant and get it, please reach out to your advisor. If they don't know it, they will help you get hours with a consultant that are included with your grant for free. And so they will find an expert to help you identify any barriers. So that's what I really do recommend. It's just kind of, if you think you can't do it, talk to somebody first. They thought they couldn't do it either. And then it's been done. So that's one of my biggest ones. It's being done across the entire country. And it's just figuring out what your roadmap looks like for you. Okay, Kaylee, we will turn it back over to you.
Thank you so much, Shawnette and Austin, for being here today. I truly appreciate it, and this is wonderful information. If you have any questions, feel free to reach out. Otherwise, we will give you 10 minutes back to your day. Again, thank you so much for showing up, everyone, and have a wonderful Tuesday.